Hi, good morning, everyone. Welcome to the second day of the Consumer Voice Conference. We're so glad to have you with us today. We're starting off with a great set of workshops this morning and are happy to have you here with us, where we're going to be talking about some new troubling data that we've been seeing, trends in antipsychotic drug usage and schizophrenia diagnoses among nursing home residents. First, a couple housekeeping things. So if you could move the slide forward, please. Thanks, Jane. So first of all, the PowerPoint slides that that we'll be going through today are linked in the session description. As are the bios, the full bios for the speakers, and I'll introduce our other speakers today. And sorry, I'm Lori Smetanka from the Consumer Voice. If you have questions with respect to for the speakers or for the session today, if you'll put them in the Q&A box up in the top right-hand corner, we'll pull from there for Q&A the end of the program, and we'll get to as many as we can. Use the chat for discussion, or if you want to make a comment, or if you're having logistical or technical questions or issues today, we have someone watching that and they can help you. If you are having any audio or visual issues, if you refresh your page, usually that takes care of most of it, but if not, put a note in the chat and someone will get back to you. We are recording today's session, and the recording will be available shortly after we're complete for today, and will be available for 30 days after the conference. You can come back in and see any of the sessions that have happened during the conference. And also please complete an evaluation for the session, and that's also linked below the session description. So as I mentioned, I'm Lori Smetanka. I'm the Executive Director at the Consumer Voice, and joining me today is Shekinah Fashaw-Walters, who has been working as a health services researcher, and Dr. Walters' program of research focuses on understanding the inequities in aging while elucidating and explicitly naming racism as a fundamental determinant of health inequities in long-term care. And she's been conducting research across the long-term services and support continuum. And also joining us today is Kelly Bagby, who is the Vice President at the AARP Foundation Litigation, and Kelly manages the office's work related to health, hunger, housing, and human services. And you can see their full bios in the link where the session description is, so please be sure to take a look at that. So next slide, please. So as we were planning sessions for the conference, we wanted to talk about work related to a campaign that we've been doing with AARP for the past 2 years around the misuse of antipsychotic drugs among residents in nursing homes, particularly those with dementia. And as we were talking about topics to focus on this year, not long before the conference came out, we had been working with the New York Times, who you may have seen articles that they've wrote and released in September and October related to increased drugging for residents, as well as schizophrenia diagnoses and among residents. And this is really the latest in what have been multiple reports and articles about the use and misuse of drugs with respect to nursing home residents. And we've actually been really concerned about not only the drugging rates, but also about changes in the rates of schizophrenia diagnoses. So, we were really glad that the New York Times dug into this issue and released the investigative reports that they had done. What they found in their reports was that current data is showing that of the approximately 1.1 million residents living in nursing homes, 21% of residents are receiving an antipsychotic drug. And that is more than 225,000 people. I mean, that's a lot of people that are receiving these drugs. And we know from clinical trials that these drugs are dangerous for older people with dementia, that really it really affects their functioning, their mind. It nearly doubles the risk of death for people with dementia from heart problems, infections, falls, and all kind of other issues. And too often these drugs are being used not because the resident has an appropriate clinical diagnosis for which they'll be beneficial and are a form of treatment, but instead to control a resident's behavior or for the convenience of staff. And when they're used that way, they are a chemical restraint. And as you know, residents have the right to be free from chemical restraints, and that does not lead to person-centered care and helping them reach their highest level of well-being. So this is something that's been very concerning. It's something that, you know, we've all been talking about for decades now. So again, we were really glad to see the New York Times article, and what the articles also showed that we've been watching is that there is a troubling increase in schizophrenia diagnoses among nursing home residents, particularly among Black residents. And if you go to the next slide, please, Jane. This slide shows the data from the MDS from 2012 through 2021. And it shows that during that period of time, schizophrenia diagnoses among residents living in nursing homes went from less than 7% to 11%. Schizophrenia is not a diagnosis that presents itself later in life. It's something that generally presents itself when a person is in their late teens or in their 20s as a young adult. And so, you know, that's something that, you know, we really have to be looking at. Why are we seeing increases in these diagnoses for people living in long-term care facilities? And are these diagnoses legitimate? I think it's a question that definitely we need to be asking. What the Times report found was that more than half of the officially reported reduction in drug use, you know, because there's been campaigns by the federal government sponsored to reduce the use of antipsychotic drugs, that more than half of the officially reported drug use was attributable to the increase in schizophrenia diagnoses from loopholes in the rules. And so, you know, it really questions what's been happening over the time of the national partnership to reduce the use of antipsychotic drugs and the work that's being done. I think it causes us to really question what's been happening and the need to look into it more deeply. Next slide, please, Jane. The Office of Inspector General released a report in May, and it was looking at additional data that was available to it, particularly related to schizophrenia diagnoses and the use of antipsychotic drugs. And essentially, it said that CMS's use of the MDS data as the sole data source to count the number of residents using antipsychotic drugs was not providing complete information. And CMS has acknowledged the potential for inconsistencies. The data, the MDS data, is self-reported by nursing homes, and you know it. So, you know, you really have to look at, is the data accurate that is being reported? And that's important because what the Office of Inspector General found when it looked at additional corresponding data was that nearly 1/3 of residents who were reported as having schizophrenia did not have any other service claims or treatment claims that were related to that diagnosis. So again, it calls into question whether a number of residents who had been diagnosed with schizophrenia were appropriately being given that diagnosis. And it's something, again, that raises a lot of questions. And that's important because when you look at the Care Compare data, where CMS releases the quality data for nursing homes, what that data shows is that 15% of residents are on antipsychotics. But again, it excludes figures for residents with schizophrenia. That's one of the excluded diagnoses that that don't get counted when you look at the facility's antipsychotic use rate, when you're looking at the nursing home compare numbers. So again, you know, if you're not seeing other treatment claims or service claims that support that diagnosis, it calls into question the data that we're seeing. Next slide, please, Jane. So, you know, as we've been watching antipsychotic drug use over the past couple of decades, obviously, you know, we have been seeing some decrease, but again, you know, we need to really look at that more carefully. But we were really concerned that when the pandemic started, that we would be seeing an increase in the antipsychotic drug use. And this data is showing that that's actually what happened. We were seeing pretty flat line. This data goes from Q1 of 2018, and this is the MDS data, the direct MDS data, through Q2 of 2021. And you'll notice that deep spike right at the beginning of Q1 1 in 2020, which is the start of the pandemic. So the data is showing that there was a very marked increase in antipsychotic drug use among residents from the start of the pandemic. And that's a pretty significant and steep increase in a very short period of time. But it makes sense, right? Because families were kept out of long-term care facilities during this time. And we know that families provide a lot of care to residents. They really supplement the care provided by staff. So it meant an increased workload for staff, severe staffing shortages that we've been hearing about across the country, with staff leaving and the staffing shortages that we've been hearing about. It all created the perfect storm for increased drug usage. But these drugs continue to be dangerous for people with dementia. And so it really does cause us to need to look at it, more carefully. And next slide, please, Jane. And, I think that when we look at, staffing issues related to the use of antipsychotic drug use, it's well documented that antipsychotic drug use increases with lower staffing levels. So again, it's not a surprise that we've seen those numbers increasing during the pandemic. So, when we're looking at the current shortages, crisis levels of staffing in facilities, the drug uses and the diagnosis changes are things that we definitely have to be looking for, watching out for moving forward as, for residents themselves, family members, as advocates. These are things that we really have to be in tune with and asking questions about. And so for their poorer quality nursing homes, which are often those with the lowest staffing levels, those residents are most at risk also to be prescribed the antipsychotic drug use. And, that leads to concerns about the use of the drugs, about the increase in diagnosis, particularly among people of color, people with low income who are living in often living in lower quality nursing homes. I mean, that has been documented well as well. And so we were really pleased to be introduced recently to Dr. Shekinah Fashaw-Walters, who did a study recently looking at schizophrenia diagnoses among Black residents with Alzheimer's and related diseases. And so I'm going to turn it over to her. And if we'll go to the next slide, please, she's going to talk about her study and her findings from that. And we'll have some then discussion after we move to Kelly. So Shekinah, turn it to you.
Right. Thanks so much for having me. I'm excited to be here and to share this work with you all. This paper was recently published within the Journal of the American Geriatric Society. So you can find the paper and the study there. And then it was also featured by the New York Times, as was mentioned. And I think Lori did a great background here for us. So there shouldn't be too much more that I have to add, but let's go on to the next slide. Which should give us some background information. And you can go ahead and load. I think there are 2 more bullets. Go back one. Perfect. I should have thought about these animations as I was submitting this PowerPoint. But racial ethnic disparities in the quality of care across nursing homes have been well documented. Black nursing home residents, as we discussed, are more likely to reside within lower quality nursing homes that are extremely segregated, and they have a higher risk of receiving antipsychotics and are more likely to be physically restrained as well. And with higher rates of comorbidities, including dementia and dementia-related behaviors, Black residents experience greater vulnerability to poor health outcomes as compared to their white counterparts. However, it's important to remember that race is socially constructed, and therefore the observed healthcare disparities that we're seeing here are not a result of biological processes. And on the contrary, they may be fundamentally caused by structural racism. Let's go on to the next slide. So I like to show this slide because structural racism can oftentimes be defined as an iceberg or described as an iceberg, where the things that we see on the very top of the iceberg are completely socially unacceptable. Those are the things that we see and we know that this is racist and this is an absolute no-no. But there are things that lie under the surface that are oftentimes hard to see. And if you go ahead and click one more, color blindness is one of those things. And color blindness relates to this idea of colorblind policies. And you can go ahead and click the next. Perfect. At the top of this pyramid here, you see these examples of the socially unacceptable forms of racism. Under the pyramid, or under that surface line, what you see are these mundane, or what would be considered mundane, racial actions or racialized actions, but these all have detrimental weathering effects. So colorblind policies, for example, are policies that don't account for the potential unintended consequences that may disproportionately impact people of color due to historic structures of disadvantage. So as we've discussed, nursing homes tend to be racially segregated. Black nursing home residents tend to reside within these lower quality nursing homes. So when we're developing policies, it's important to think about those historic structures that already exist in order to shape policies that will actually support and advance care for everyone. Let's move to the next slide. So in March 2012, and you can go ahead and load the bullets here, but in March 2012, the Centers for Medicare and Medicaid Services, as we discussed, implemented this initiative around the national partnership to improve dementia care in order to decrease those antipsychotics. As you all know very well, this followed 2 FDA black box warnings and a continued use of antipsychotics. But as we talked about in the calculation of this quality measure by the partnership, nursing home residents with specific conditions of schizophrenia, Tourette's, and Huntington's are excluded from that measure of quality. So this leaves the door open, as you all know, to these unintentional outcomes of exacerbating these disparities in schizophrenia and labeling folks as having schizophrenia. So that was the purpose and objective of our study, was to look at this. So we can go to the next slide. We examine how race and dementia together, how those two statuses influence the rate of schizophrenia reporting among nursing home residents before and after the partnership. We hypothesized that following the partnership, there would be racial differences where Black nursing home residents would experience greater increases in schizophrenia as compared to their non-Black counterparts, and that this would be heightened by the presence of dementia. Let's go ahead and move to the next slide. Here, I talk a little bit about the methods, maybe my least favorite thing to talk about here. But if anyone's interested, we use a difference in difference regression, where essentially we look at the introduction of this policy. Does the trend in schizophrenia change by race and ADRD status? So again, we're looking at the presence of schizophrenia. We're looking at the impact of both dementia and Black race as identified on your MDS assessment. And then we control for other characteristics. So age and sex, we control for function and frailty, and we also control for those behavioral expressions of dementia that we believe oftentimes nursing homes may use antipsychotics to control. And so the thought for controlling for these factors was that, especially in doing disparities research, a lot of people will oftentimes say, oh, that disparity, it only exists because Black people and non-Black people in nursing homes look very different in terms of their underlying characteristics. But we use our regression analysis to control for that. So the differences we're seeing are actually there. So let's go ahead and move on to the next slide. This slide here just sort of gives you the basic characteristics of the population over our study period. There's nothing super surprising or concerning here. We also see that schizophrenia rises from about 4.9% to about 6% over our study period, but age stays pretty consistent. We see changes in the makeup of male versus female sex within the nursing home. We see a difference in the percent of nursing home assessments that indicate Black as the race, but very, very minimal changes. And we see that a lot of these other characteristics remain pretty consistent over time. We can go to the next slide. So this is where things get interesting. When comparing residents with and without dementia, schizophrenia reporting was highest amongst residents with dementia. In the population without dementia, we see an increase of about 1.9% for non-Black residents after the implementation of the national partnership, and we see an increase of about 2% for Black resident assessments within that non-dementia population. But then among nursing home residents with dementia, what we see is a 1.7% decrease in schizophrenia reporting for non-Black nursing home residents, but a 1.7% increase in schizophrenia. If you're like me, you don't necessarily like to see all these numbers. So let's go to the next slide. And there is a table or there's a figure here that can help you visualize what's happening. So after the introduction of this national partnership, we see a decrease for most, and this is controlling for all the other resident characteristics we can think of. We see a decrease in schizophrenia reporting or schizophrenia diagnoses amongst all of these nursing home residents, except for the Black nursing home residents with dementia, which are represented by that maroon and sort of dashed line at the very top of the graph. We also see that the change that happens between the two groups is largest for our population that's living in the nursing home with dementia as compared to those who aren't. So if we go to the next slide, I can kind of summarize that again. Once again, following this partnership, we see this increase in schizophrenia, but only amongst those Black nursing home residents that have dementia. And that greatest difference or that greatest change happens within our dementia population. And then finally, let's go to the next slide, Jane. I like to share some of the implications of this work. And as a health services researcher, I think a lot about sort of the next research questions and the next steps, but I'm happy to engage in conversation around policies and what this might mean for advocacy if anyone has any more questions once I'm done here. But these findings, ultimately could reflect racial disparities in schizophrenia diagnoses, quality differences in nursing homes for Black versus non-Black residents. But I also do like to point out that within this study, we are looking within the same nursing homes. So most of the racial disparities that we see within nursing homes are across nursing homes, which tells us that Black nursing home residents are going to different types of nursing homes or lower quality nursing homes than their white counterparts. But here in this study, we see these disparities within the same nursing home using some fancy statistical methods that allow us to kind of create the same sort of nursing home for folks and simulate that in different ways. So what we see here is somewhat contrary to past racial ethnic inequities literature in nursing homes and raises even more concern about how Black and Brown nursing home residents are being treated even within the same nursing homes. And then, there's also some concern about staff perceptions on how to manage behavioral expressions of dementia, which we oftentimes see more often within Black and Brown nursing home residents. And then, of course, as we discussed in the very beginning, structural racism might be a very large part of what we're seeing. This colorblind policy is not one that's created, or it is one that's created to support everyone, but without the historic structures that have been put into place, it's difficult to sort of balance and make sure that all residents really are receiving the higher quality of care. And so that's why we see this increase in schizophrenia, specifically amongst one group. In terms of antipsychotic work and antipsychotic use, I think more work really does need to be done to create a method that is able to adjust for these potential increases in coding of schizophrenia while measuring the changes of antipsychotic use. I think as Lori alluded to, it's really difficult to to see the CMS measures online on Care Compare and really think that those are the true measures of antipsychotic once we have information about exclusionary diagnoses increasing. And then, I think lastly, future work should also look at the initial diagnosis of schizophrenia to determine if it occurs during the nursing home stay, which from what we've heard today and what we know is very unlikely. And I will stop there. We can go to the next slide. And I don't know if Lori wants to do questions now, or we can come back to questions after, and you can feel free to load that slide. Thanks.
Yeah, if we can go to Kelly, and then we'll come back to questions at the end. Thanks. Thank you, Shekinah.
Thank you, Shekinah. That was really informative and very thought-provoking. So I just want to back up a minute and talk about why are we talking about this? And why is this happening? Why are so many people in nursing facilities getting these drugs? And I think part of it goes to the deference that all of us give to doctors, quite frankly. If a doctor is prescribing something for us, whether we're in a nursing home or we're living in our own home, we're generally going to think that that doctor is doing that for our benefit. And that's even more so true when you have a captive audience, as you do in a nursing facility. So these drugs are given off-label, which really masks the dangers of them, to say that you're getting, because off-label is also, you can have off-label cancer treatments. And we think that's a good thing because that's something innovative. And somebody's discovered that this drug that is used for high blood pressure can also treat tumors. And so these antipsychotic drugs, when given to people with dementia, are given off-label. And there's a lot of euphemistic words that are used to mask the dangers of what it is we're talking about. So, when you go to look at, I was just reading manuals for pharmacists that work with people in long-term care, and they've got new terms to describe what it is they're doing. They're treating behavioral psychological symptoms of dementia, and then they abbreviate it BPSD, so that you can see that you're constantly moving away from the fact that you're giving a drug to somebody to treat something that it does not treat. There are no drugs, antipsychotic drugs, that treat dementia. It just doesn't happen. There are other kinds of drugs that work to treat dementia, but antipsychotic drugs do not treat dementia. What they do is they quiet a person down and make them more easily handled in a nursing facility. And if you're in a nursing facility and you're short-staffed, that's a good thing for you, because you need people who are not expressing and communicating their unhappiness, or they're trying to communicate to you maybe their pain, or maybe they're trying to communicate to you their boredom or their frustration or their fear. But they're communicating. And so masking that communication with drugs is a very dangerous thing, because now you've quieted the person down. They can't communicate something that may be essential that they need to communicate to you, that they have an infection or they have a fever and they can't find the words to tell you. So they're communicating in other ways, maybe by hitting the wall or screaming out, but they need to communicate. So rather than trying to figure out, because maybe you're short-staffed or you don't have the tools yourself to understand what it is that's communicated, you reach for an antipsychotic drug to quiet the person down. And that is why Lori was describing this as a chemical restraint. It's a restraint to just quiet the person down so that they're no longer disturbing the milieu, as they say. Other words to be very watchful of when you're doing advocacy for people in nursing facilities or any long-term care setting are words like agitation. When you see words like agitation or behavioral disturbances or exhibiting behaviors or psychosis, these are all words that are very loaded, and they're being used like the diagnosis of schizophrenia now is being used to paper over the use of this drug or these combination of drugs. So back to why is it happening? there have been a long history of off-label promotion of these drugs. Off-label use of drugs is not itself per se illegal, but off-label promotion of that use is very much illegal. So I now work at AARP Foundation Litigation, and I litigate cases, and my office litigates cases on behalf of nursing facility residents who unfortunately usually die as a consequence of having had these drugs. And sometimes we've been able to, help classes of people to prevent people from dying. But what you see is that when people get these drugs, different people handle them differently. And so we've had clients that can take these drugs and then realize the family or the person realizes that they're poison basically to them, and they can get themselves off of the drugs. But that is not true for many people. Some people, like I can't take ibuprofen. It actually is deadly for me. So I'm sensitive to that. Some people are deadly sensitive to Risperdal or Zyprexa. And if you give it to them, it's a poison to them. And so it really depends on what other things people have going on in their lives, whether or not the drug will be lethal in one dose or lethal over time. But Lori was describing how the drugs, many of these drugs have black box warnings. And what a black box warning is, it's the highest warning that the FDA can give a drug. Highest warning. That's why it's literally it's written a black line, like a black Sharpie around the box. But when the drugs are prescribed, obviously they come out of the box. So nobody else sees the box other than the pharmacist. But the studies that justified the FDA giving these drugs a black box warning were studies involving usually people in their 60s. And they did, as Lori said, they had 5 times the rate of death for people in their 60s. But imagine if you give them to someone who is 85, and the rate of death could be far, far greater than 5 times the rate. So if the drugs are, depending on the person who they're being given to, can be lethal in one dose or lethal in a week. I've had a client whose mom was she never had any psychological issues at all. And she went in to the nursing facility with a broken hip to rehab because she had her hip replaced. And so they had her literally, unfortunately, physically restrained to her wheelchair, which made her very uncomfortable. And she was not particularly verbal at that point because of the having just had surgery. So she kept trying to get out of her wheelchair. And so they kept every day, you see the notes, and every day they're giving, she's agitated. So that every day the doctor is writing a script, sending it to the nursing facility, and they're layering on new drugs over the course of 3 weeks. They added about 12 different drugs in the course of 3 weeks. And the daughter was the only person who could have legally consented because she was the medical power of attorney. And her mom at that point lacked capacity because of the surgery. So the daughter comes in and she's like, "What the heck did you do to my mom? Why does she look completely drugged up?" And they were like, "Well, she was agitated. She was acting out and she was agitated." So the daughter quickly took her mom out, which is not something that every family member can do, obviously. She took her mother to the hospital, and tried to detox her out of those drugs, and she died within a week. So that's 4 weeks from admission to death, and the layering on of a variety of drugs. So, but again, without consent and without anybody explaining and nobody considering alternatives to what else could have happened. I do want to go back to the ways in which the practice of giving these drugs as chemical restraints is masked. I'm investigating a case right now where, I'm sorry, it's really cold in my basement, so I'm shivering. I'm investigating a case right now where we see something that we call diagnosis creep, which is you read, a year's worth of records and you don't see any reflection of schizophrenia or psychosis or any of these things. Then suddenly up pops a diagnosis of psychotic or history of schizophrenia. And they are suddenly that same day also is prescribed Risperdal. So this is the prime example of diagnosis creep, where suddenly a diagnosis coincides with the prescription of an antipsychotic drug within, it doesn't have to be the same day. Sometimes it can be within a week. So this is a way that the use of these drugs is legitimized. It's legally legitimized once you tie the diagnosis to the drug, or the drug to the diagnosis, then you can justify giving it. And that it's very, very troubling to think of. From 2017 to now, there's been there was a 2017 study that looked at the incidence of schizophrenia being added into people's diagnosis, and there, from a very short period, the incidence of schizophrenia doubled in that study. And excuse me, that's actually not scientifically possible. You don't just suddenly have a whole, unless you're moving people from a psychiatric hospital into nursing facilities all simultaneously, you're just not going to see the huge increase of the amount of schizophrenia. It just defies the national research that there are suddenly all these people with schizophrenia in nursing facilities. But the schizophrenia diagnosis is just one. I want to just be very specific. It's just one way in which this is happening. The OIG focused on the incidence of diagnoses of schizophrenia as the way that they were calculating, because that's what they were looking at. They wanted to see, from a payer's perspective, does this self-reporting of schizophrenia defy because that's what's reported on the MDS data, does that defy what it is we're trying to look at, which is we want good data about why people are being drugged. But there are many insidious ways that this is happening to people, and I really want to make sure that we are all very aware. At least I'm happy to share my experiences over the last 15 years of litigating these cases. And then when I also worked at the Office of the Inspector General doing litigation there. And we saw this, 15, 20 years ago starting to happen, where you have a certain treatment modality you want to use because that's the treatment modality that the people in your nursing facility are comfortable with. And so you adjust the diagnoses to fit the treatment modality. And so we see this in a lot of chains, nursing facility chains, where they and maybe so sometimes it is even more insidious and based on greed and based on kickbacks. So there was a series of cases that I believe that my slides from this are up on Consumer Voices page, and I apologize that I don't have them here. But there were a series of federal enforcement actions brought against a variety of drug manufacturers for paying kickbacks to long-term care pharmacies that are connected to nursing facility chains. And so they were paying these kickbacks to get their specific drugs into the nursing facility chains. And so that becomes the treatment modality of that nursing facility chain, because they have all these drugs that they've now paid to get used. So the kickbacks went both ways. The manufacturers were paying kickbacks to get the drugs into the pharmacy companies that are connected to these long-term care chains. And then the pharmacy companies are getting kickbacks for taking the drugs back, taking the drugs in. But that then becomes your treatment modality. And so but that is not in any way tied to the needs of the residents of the facility. And the needs of the residents should always be the only thing that matters when you're running a long-term care program. So I just was reading again from the pharmacy perspective. So I think we should always talk about the pharmacists when we talk about this, because the pharmacists are the ones filling these scripts. And the pharmacists are people who should not be filling scripts that are not tied to a diagnosis. And it is their job in a long-term care setting to ensure that the script matches the diagnosis. This has led to some of this problem, obviously, because if you say schizophrenia as the diagnosis, then the pharmacist is now off the hook. And that's a big part of what's happened here. But similarly, if you say psychosis, you should see some justification for it. You should see some evidence of psychosis. But more importantly, a pharmacist should be asking what non-pharmacological treatments have been tried here before there's just suddenly we're talking about a very serious mind-altering and physically body-altering drug. So the pharmacists need to be the ones asking these questions, but so should the CNAs, and so should the RNs, and so should all of the treatment staff that sit on a treatment team at a care planning meeting, and they should question. They should say, "Is this drug really necessary?" Virtually every nursing facility chain that I've investigated or sued has a policy that says we should always be considering how to get somebody off of an antipsychotic drug. But that should be a meaningful conversation, not just a checking off of a box where you say, "Did you consider non-pharmacological things?" Yes. And what were the non-pharmacological? And they write down, assessed all different non-pharmacological things. It actually needs to be a meaningful conversation. And any of you that are asked to participate in a care planning meeting, you be that voice at the planning meeting. You need to be that voice and say, what is it that is leading to this drug being continued? If it started in an emergency room, or it started after a short hospital stay, it doesn't need to continue just because it was started. And this is part of the questioning that has to happen at care planning meetings. Why are we doing this? What are the alternatives? What did we consider? What did we try and fail? Was that documented? And if it wasn't documented, then let's come up with a plan to taper off of this. Sometimes, unfortunately, a lot of nursing facility staff allow inertia to be the dictator of treatment. So if somebody's already on a drug, it's easier to not try to taper them off, because tapering people off of these drugs is not easy, but continuing them on the drugs could be fatal. And so it's critical that all of us everybody that is listening to this conference, and you tell everybody that you know that there should be an unacceptability of using these drugs in nursing facilities unless a person genuinely has a mental health diagnosis that will benefit from these drugs. And those exist. I'm not saying they don't exist, but not 1 in 5 people in nursing facilities has a diagnosis. And that's the utilization of these drugs is 1 in 5 people are getting these drugs. And there's no way that the science supports it. So what we need to do, and Lori's going to talk a little bit about the campaign that AARP Foundation and Consumer Voice are running. But what we need to do is reverse the acceptability of this. We should just be flat out saying this is unacceptable, rather than, this person is on this drug, it's going to be hard to get them off. Let's just leave them on it. Let's just roll the dice and see what happens. That's unacceptable. And so I think that's why my answer to it, because I'm a litigator, is to sue people. But that's a lot of lawsuits we'd have to bring. The easier solution is if we can change the culture and make the use of these drugs completely unacceptable, except in the small number of people for whom it is a genuine treatment. But these drugs do not treat dementia. They only mask communication. And so with that in mind, we should be able to help to change the culture a little bit and say, you know what, this is truly something that we need to make sure that the policy people are listening, but also make sure the law enforcement people are following up on this, because it cannot be that you can paper over something so deadly with just a diagnosis, just a coding diagnosis. Someone just said, how about a class action? The first case I brought on this, I brought it in 2011, so 10 years ago, was a class action. And we won it. And it was a case, it was the woman I just was describing, the woman whose daughter found her mom after 3 weeks totally drugged up. And so it was the doctor in that case had testified that he never once got informed consent for anybody ever. and when he prescribed antipsychotic drugs, because his argument was, if you're in a nursing home, you're consenting to any treatment that we will give you in the nursing home. And therefore that tied our whole class action together, because he just admitted that he's never once got informed consent for anybody. So in California, we could use that as the way to tie the whole class action together. But I agree. I agree litigation is a great tool, but policy change and enforcement of policies by states is a more expansive way to tackle this. And I think the re-education of our treatment staff is also critically important, because we need the CNAs in these facilities to say, why is Mrs. Jones on that drug? I'm not comfortable with her being on that drug. We need the people in the facilities to raise their voice with the caregivers, with the families, and say, this is unacceptable. We will not tolerate this anymore. And I think that's the real wave of change that we need to see, because this is a cultural, you saw the chart that Lori put up there, that this has been an ever increasing, and then with a spike during COVID, but this has been an ever increasing cultural problem that has taken place over the last 20 years. And it's really hit its stride during COVID. And there's no reason to think that it's not going to go away by itself. We have to change it. And so that's why I believe I'm very grateful for all of you listening here, and for Shakina's research about the racial dynamic to this. There's also a poverty dynamic to this that I want to leave you with, and that is in the Medicaid facilities, the facilities that are primarily Medicaid recipients, they are absolutely much more likely to have everybody in the facility getting antipsychotic drugs. There was a person I interviewed in an investigation, and this is, I hope this isn't true, but I have no reason to believe this person was lying to me. It was a staff inside the facility who told me that when the surveyors were coming into the facility, they would drug every single resident so that they were all very compliant, and that the surveyors did not see how disruptive the environment was. So they just when they knew the surveyor was coming in, everybody got their antipsychotic drugs that day. So this is the acceptability of this is the problem, and it is not acceptable, and we shouldn't tolerate it. Lori, I'm going to turn it over to you for questions.
Okay, great. Thanks so much, Kelly. Some absolutely important points that you raised, and thanks for running through the reasons why these are absolutely unacceptable. If you go to the next slide, Jane. So as we've mentioned a couple times, the Consumer Voice is working with AARP on a national consumer education campaign on avoiding drugs used as chemical restraints in order to change the culture of care. And we're sharing information about not only the use and misuse of these drugs, the dangers of these drugs, but also what good care looks like and questions that people can be asking. And if you go to the next slide, Jane, we have a whole range of resources that we have on our website. We're continuing to develop new things that will be posting, doing educational programs like this one to talk about these issues, and really trying to educate people, residents and family members particularly, but also those of you who are advocating for those that are living in long-term care facilities, to know what questions to ask, what are things you should be looking out for in order to address these issues, because certainly it's by raising questions, by questioning the status quo of the use of these drugs, about what's happening with residents, and insisting that better solutions, non-pharmacological solutions, be implemented, that we are going to actually be changing the culture for all residents. So if you go to the next slide, we'll turn to some Q&A. A number of questions have been coming in for us, so I'm going to turn to those now. Okay, so we'll start with, in the early 90s, after implementation of OBRA and restrictions on chemical restraints, they began doing look-behind surveys to validate that state surveyors were complying with standards. Has CMS demonstrated interest in resuming federal inspections to ensure that states are consistently enforcing regulations pertaining to chemical restraints? So CMS does do look behind surveys. They do a certain percentage every year, and actually look behind surveys often find many more problems than the state surveys do find. And CMS has actually also been having surveyors in many cases focus on the misuse of the use of antipsychotic drugs with residents when they are doing their survey. So this is something that does need a lot more attention. The focus on antipsychotic use has not been done to the extent that it's supposed to be, that CMS is wanting it to be. They actually had intended to be targeting surveyor attention to this use, but the pandemic has caused them to kind of bump out the implementation of that. So this is something that we will definitely be pressing them on more. Kelly or Shekinah, I don't know if you had any comments on this one.
No.
And if not, we'll go ahead. Okay. So do the demographic or racial disparities that Shekinah, that you were mentioning, hold in the community setting, and how do they compare to nursing home incidents?
Yeah, that's a great question. And one that I believe the research team at Brown is still continuing to ask about sort of that spillover of this national partnership into community settings, whether it's assisted living or even home and community-based services that focus more on home health and that sort of thing. So we don't know the answer to that yet, but folks are definitely interested in finding that out. So
Great. Helps. So that's a stay tuned. Let's watch for more information to be coming about that one. So there are a couple of questions about how can an advocate or a family member recognize, what's going on with residents and how to advocate for change. So Kelly, might you want to start with that?
Yeah, I think that's an excellent question. And I think that's also one that we, in our joint campaign with Consumer Voice, we work on quite a lot and have developed some tools that are on Consumer Voice's page, and they're also on ARP Foundation's page, that are kind of tools you can walk around with. There's a list of the different drugs that you need to be incredibly watchful of, that I think is the first place to start. Like you would not necessarily, if somebody tells you we're giving this to your mom for agitation, you're not necessarily going to like go, oh gosh, what is that? You would need to know that the drug, and you can just Google it yourself. And if it's an antipsychotic drug, then you should be watchful. But not only are antipsychotic drugs dangerous, there are nursing facilities giving things like Depakote, which is a seizure disorder drug. But it's Depakote has this very similar response to people's that antipsychotic drugs do, and it can cause the same sort of deterioration and lack of so these are the watchful things to be careful of. You see somebody who's shaking, that's obviously a very, very dangerous sign. But if they are not well hydrated, they're not eating, these are natural consequences of taking these drugs. If you see somebody who is like lilting to the side in their chair, they have a hard time just sitting upright, or their face seems like it's just really like hanging down a little bit, those are signs of listlessness, and that you want to be very careful about. If somebody is suddenly confused, we had a client who was like crackerjack trivia person, like the top trivia person in her independent living, and she went into the nursing home and she could barely remember like what her grandkids' names were, and that is a telltale sign of a person who's getting these drugs. They don't seem like themselves. That's what families describe to me. Like, my mom just doesn't seem like herself, and that the problem is probably tied to an antipsychotic drug.
Mm-hmm. And certainly, if you're working with a resident or family member and they're concerned about some of the symptoms that Kelly is talking about, they definitely should be asking for a care plan meeting, asking, what medications the person's on and what are they for? Like, specifically, what is this medication to treat? What symptoms are they supposed to be treating? What diagnosis is it supposed to be treating? And asking if there have been non-pharmacological alternatives that have been implemented and what they were and how long were they put into place. Like, it's one thing to say, well, we tried, X, Y, and Z therapy for the person. But if it's a one and done deal, that may not have been enough. So there should be a series of non-pharmacological interventions that should have been tried before, that should have been tried, and not even before an antipsychotic has been diagnosed, but in order to even help wean a person off. So I think, there are a number of things. And we do have, as Kelly said, tools on our website. We have cards that can be given to family members and that Ombudsman can use to kind of look at questions that you can ask. We've got fact sheets and a range of other materials.
The other thing, Lori, that I would say is don't just ask the question. If you have access to the record, go look at the record, because you need to actually see what it is that they have written in the record. And I think that there's a lot of times they'll tell you, we're giving her something for this, and they'll tell you euphemistically that this is something to help with her agitation. You don't want her to be agitated. She's terrified. You don't want her to be terrified. So let us just give her this, and it'll help calm her down. So you need to actually go pull the record or look yourself, or tell them, I want to see the medication administration chart for the last month, and I want to see the doctor's order that authorizes whatever it is you're giving. And again, I can't tell you enough how many families have come to me shocked that their family member is on this drug and no one had any idea. So it happens in the dark of night. I don't know how else to tell you. Like, families often are like completely blown away that their family member is on this drug, and then once they're on it, they feel powerless to do something about it because they don't know how to stop it.
Absolutely. Would a pattern of new diagnoses for residents with dementia in a facility warrant trigger for an ombudsman or a family member or someone to report to the state Medicaid Office of Inspector General? Kelly, do you have thoughts on that?
So the question is that, I'm sorry, could you read the question one more time?
Sure. So would a pattern of new diagnoses for residents, so if an ombudsman becomes aware that suddenly there's a lot of new diagnoses for residents, should they report that to the Office of Inspector General or Medicaid fraud?
Yeah, I would also, though, start with the state survey agency and really make sure that you need to make the states investigate these complaints. Like, we have to start there, because if we don't start documenting every time that any of us see this in a nursing facility, people like Shakina aren't going to be able to do the research that she needs to do. We have to have data to be able to show that the patterns of what is happening, and we need it to be at the lowest level, at the state levels. But yes, I think that you can, the Office of Inspector Generals, they have special agents in each state, and you should definitely try to reach out to the special agents in your state at the Office of Inspector General to tell them if you have concerns about a facility where you just, or if you see that everybody's on the same drug, like that we've had complaints about this, that everybody's on Risperdal. Like, why? How is that possible? That everybody needs exactly the same drug? That something is wrong there.
Absolutely. Shekinah, what policies could be implemented in this area that move away from a colorblind mentality to a more conscious acknowledgement of structural racism? Do you have any thoughts about that?
Yeah, that's a good question. I think the first thing that comes to my mind is making sure that CMS is thinking about these measures by race, even if that's not information that they make public or share broadly. This is something that they should be examining and looking at by facility to be able to target facilities that need a little more special attention and intervention. I think also providing targeted support, as was mentioned, to these Medicaid-reliant nursing homes is really important, because we know that Medicaid-reliant nursing homes are also predominantly Black or brown nursing homes, and these are the nursing homes that need support. So, I mean, in a grand scheme of things, there's nothing wrong with this national partnership, but there needs to be some tailored focus around supporting those facilities that don't have the resources necessarily to seek other ways to provide care and to intervene with the behaviors that they might be most concerned about. So I hope that helps.
Absolutely. Well, I know we could probably talk about this for hours more, and this, I think, we've been having this conversation for quite a while, and I know we'll be continuing the conversation, and hope that Shekinah and Kelly will continue to join us in the future as we talk about this more and work on not only advocacy strategies, but solutions to addressing many of the issues that we've been dealing with today. So as we're coming to a close for today's session, I would like to thank Kelly and Shekinah for joining us today, for sharing the great information. Thanks so much for all of your questions. I know, sorry that we didn't get to all of them, but we will go back and look at them and try to incorporate some of the questions or suggestions that you mentioned into the work that we're doing as part of the campaign, and work to address them in the future. So thanks so much. We have a next session coming up in a few minutes, or in a half an hour. So thank you. Have
Thanks,
a great
Lori.
rest of the day.
Thanks, Shekinah.
Bye-bye.
Bye.